In this video, I'm going to teach you my approach to heart failure. And I remember as a medical student, it was very confusing learning this topic for the first time. So first, I'm going to give you briefly kind of signs and symptoms to look out for with heart failure. And then we're going to talk about management and kind of the key things that you need to know when you're approaching heart failure. So talking about heart failure, the first thing is to understand what is actually going on with heart failure. And the main thing is that if I draw a heart right here, and I'm just going to draw a little human body here too, sorry for my poor drawing skills. What happens is that for some reason, the heart is not pumping well. Either it's because of an afterload problem where there's too much pressure that the heart is having to push against, or there's a contractility problem where the heart is just not generating enough force to push blood flow forwards. So instead of blood flow going forward into your aorta and then kind of in your systemic circulation and everything like that, instead what you're going to get is all of the blood that was supposed to go forward starts backing up in your body. And so the first place you see that is going to be in the lungs. So you'll see pulmonary edema, and you'll get signs and symptoms like shortness of breath, dyspnea on exertion. You'll get pleural effusions, pulmonary edema, and some key history findings on exam, such as orthopnea, which is when somebody is unable to lay flat because there's so much fluid in their lungs. And then also what's called paroxysmal nocturnal dyspnea, which is when somebody wakes up in the middle of the night feeling short of breath or gasping for air, again, because there's so much fluid in their lungs. You'll see these findings on chest x-ray as bilateral hazy opacities with a bat wing appearance, as well as pleural effusions and just kind of vascular congestion in general. Beyond backup of fluid into the lungs, you're also going to start backing up into more of your venous system as well, particularly the jugular vein that's right here in your neck, and you're going to get what's called increased jugular venous distension. You're also going to get potentially congestive hepatopathy, so your liver is here, and if it gets very congested with fluid, you'll start to see LFT abnormalities. Typically, this is going to be an indirect hyperbilirubinemia rather than a direct hyperbilirubinemia like you would see with obstructive disease or gallstones or things like that. And then finally, a huge component is also backup of fluid into the legs. So you will start to see swelling in the legs called peripheral edema. You also may see some stretching in the chambers of the heart, particularly the atria, which will increase the release of what's called BNP, or beta natriuretic peptide. Again, these are all caused by poor forward flow of the heart, leading to backup of fluid into the rest of your systems, like your lungs and your venous system. So let's move on to the management of heart failure. And the first thing that's key to figure out is whether this is systolic heart failure or if this is diastolic heart failure. And I remember being very, very confused about this when I first started medical school and even intern year. Systolic heart failure is nowadays more commonly referred to as heart failure with reduced EF, and diastolic heart failure is heart failure with preserved EF. And then we actually have this etiology in the middle, which is called heart failure with mildly reduced or mid-range EF. Why is it so key that we differentiate between HFrEF and HFpEF and even HF mildly reduced EF? The main thing is because the treatments completely vary based on what the patient's EF is. One thing I like to ask all the medical students that I'm teaching is, what are the cutoffs for systolic heart failure and diastolic heart failure? And the answer to that is systolic heart failure is an EF less than or equal to 40%. HF mildly reduced EF is going to be 40 to 50%. And then diastolic heart failure is an EF of greater than 50%. You may remember from your preclinical years that systolic heart failure is associated with adaptations called eccentric hypertrophy, and diastolic heart failure is associated with concentric hypertrophy. The way that I like to explain eccentric hypertrophy is by drawing out the four chambers of the heart. And you can see here, this is going to be your left ventricle right here. And what happens with systolic heart failure is often you get like a heart attack or some kind of scarring or some other problem, which ends up leading to the walls becoming very thin and dilated. And basically, your systolic function, or the ability of the heart to pump blood flow forward, becomes very reduced because of how floppy this left ventricle becomes. On the other hand, with concentric hypertrophy, a lot of times you have increased afterload of the heart, which is increasing the strain on the heart, and then it starts becoming very, very hypertrophic with a really, really thickened wall. And what this leads to is reduced filling of the ventricle. So blood is not able to get in there as much because it's so stiff. So that's why the patient's cardiac output drops and they're not able to pump as much blood forward as they should be. You may also hear some people refer to systolic heart failure as a dilated cardiomyopathy because the left ventricle is becoming dilated. However, it's not actually entirely accurate, and Strong Medicine actually has a really wonderful video, I'll link it down in the description below, describing how dilated cardiomyopathy is not actually a consequence of ischemic heart failure. This is a little bit more of an advanced topic, but you'll see this mentioned all the time. People say it's like dilated cardiomyopathy because the chamber is dilated. So I just wanted to point that out for you, just in case you get confused with different terminology that people use. In terms of etiology, for systolic heart failure, we really need to differentiate, is this an ischemic etiology or is this non-ischemic? And the most common ischemic etiology is going to be, coronary artery disease or a heart attack, a myocardial infarction. Whereas non-ischemic, we typically think of things like drugs or viruses, and then less commonly, drinking, pregnancy, genetic disorders, chemotherapy, left to right shunts, and Takotsubo's cardiomyopathy, which is a stress-related or stress-induced cardiomyopathy. So why is it so important for us to know if a patient's systolic heart failure is caused by an ischemic cause or a non-ischemic cause? The main reason is because this is going to affect management. So we know that patients with ischemic causes of systolic heart failure are at much greater risk for arrhythmias. And so there's a much lower threshold for these patients to get an ICD or an implantable cardiac defibrillator device in order to prevent sudden cardiac death. Whereas patients with non-ischemic cardiomyopathies tend to have a lower risk of fatal arrhythmias. So higher risk for arrhythmias. Moving on to the management of HFrEF, there are really 4 key pillars that all patients with HFrEF need to be on. And so we call this the 4 pillars of systolic heart failure management. And that's going to be a beta blocker, an ACE, ARB, or ARNI, which is also called neurohormonal blockade. And then there's going to be SGLT2 inhibitor, and mineralocorticoid antagonist therapy. All of these are shown to improve mortality in systolic heart failure, which is why it's so important to get all these patients on these medications. You will frequently hear this referred to as GDMT, or guideline-directed medical therapy. Don't get this confused for people saying goal-directed medical therapy. A lot of people inappropriately call it goal-directed medical therapy, but that's actually referring to the treatment of sepsis back in the 2000s. It's actually, GDMT stands for guideline-directed medical therapy, so make sure you don't get that wrong. Again, all of these therapies have been demonstrated to have significant mortality benefit in patients with HFrEF, and there are multiple trials proving the beneficial effects of these medications, which I actually discussed in my heart failure phrase video that I'll link in the comments, the description down below as well, if you want to check out the different studies and trials which found these results. In terms of beta blockers, there are 3 beta blockers that have proven mortality benefit, and that's going to be bisoprolol, metoprolol succinate, and carvedilol. In terms of figuring out how to choose between these different beta blockers, one thing that we typically do is assess if the patient has reactive airway disease. If that's the case, then typically we reach for bisoprolol. So bisoprolol is good if there is reactive airway disease. This is because bisoprolol is thought to be a little bit more cardioselective and have less effect on the beta receptors in your lungs. Obviously, if somebody has COPD or asthma, they're treated with beta agonists. So if you give them a beta blocker, that can actually worsen their reactive airway disease unless you choose a more cardioselective medication like bisoprolol. Metoprolol succinate is an excellent medication. You really need to know the difference between metoprolol tartrate and metoprolol succinate. So succinate is the only one with proven mortality benefit based on these studies. The reason we use metoprolol tartrate, you should think of it as titrating the medication. So metoprolol tartrate is twice a day medication, so BID, whereas succinate is kind of the extended release medication, and it's once a day. And so a lot of times when the patient's in the hospital, we start them on metoprolol tartrate just to see, what they're able to tolerate. And then we continue to up titrate their dosing. And then once they're close to discharge, we will switch them over to the equivalent succinate dose, because that's the one with proven mortality benefit. And basically the dosing is equivalent. So if somebody's on metoprolol tartrate 25 milligrams BID, that's going to be equivalent to metoprolol succinate 50 milligrams daily. So that's how you convert them from each other. And then finally, we have carvedilol. So carvedilol is again going to be a BID medication. So if somebody is struggling with adherence issues or polypharmacy, a lot of times we may favor metoprolol succinate over carvedilol just because it's a little bit easier to take a once a day medication than twice a day. But carvedilol does have some advantages in that it has both some beta blockade as well as alpha blocking capabilities as well. So that actually helps with blood pressure control and helps patients get a better blood pressure. There are some studies, such as the COMET trial, which did show that carvedilol may have some slightly improved outcomes compared to metoprolol succinate. And this is thought to be due to some changes with improving insulin sensitivity, whereas metoprolol succinate doesn't improve it. There's all sorts of theories about why that's possible. But that's why if you're really not sure whether to choose metoprolol succinate versus carvedilol, you could probably choose carvedilol if there's no other reason not to choose it. For choosing an ACE, ARB, or ARNI, some typical examples of an ACE would be like lisinopril, and an ARB would be losartan, and then an ARNI would be Entresto, which is called valsartan sacubitril. A lot of times we start with an ACE like lisinopril because it's going to be the most cost effective. It's going to be the cheapest one for patients. However, remember that ACE inhibitors have that potential side effect of a dry cough, in which case we switch to an ARB. And actually, a lot of times nowadays, we just could probably start with an ARB, although at my institution, we typically still start with an ACE because ARBs are relatively affordable now as well. So you could just start with losartan. And the best evidence for improving mortality is actually with the ARNIs, such as Entresto, because of this trial called the Paradigm HF trial, which compared ARNIs versus ACEs and saw improved outcomes in the ARNI group. One thing that you may need to note about switching from an ACE to an ARNI is that you have to have this 36-hour washout period where you're not using the ACE before you can take the ARNI. If you're taking an ARB, you could actually directly just transition to the ARNI right away. And for me, I typically actually don't like ARNIs that much because you have to send it through their insurance to make sure it's covered. Otherwise, it's super expensive. And in my personal experience, every time I've used ARNIs, people get really, really hypotensive a lot of times. They've had like falls and stuff. So based on the guidelines and the recent trials, you should be using ARNI as much as possible. But I will just give you a little bit of a warning about that potential side effect that it's going to drop their blood pressure a little more than the other medications. These are basically the two that you want to definitely prioritize starting right away. But as soon as possible, you also need to get them started on their SGLT2 inhibitor and mineralocorticoid antagonist as well. So your options for SGLT2 inhibitors include empagliflozin, dapagliflozin, canagliflozin, all those ones. And this is with or without diabetes. It's still shown to have mortality benefit in patients with HFrEF. So you just give them a 10 milligram dose instead of a 25 milligram dose. Their GFR does have to be greater than 20 in order for you to give this. And then for mineralocorticoid receptor antagonists, this includes spironolactone and eplerenone. So we start with spironolactone, and then if patients are having side effects like gynecomastia, then we switch them over to eplerenone. But oftentimes we have to run it through their insurance to make sure it's covered. So again, those are the 4 key pillars of guideline-directed medical therapy. Now, there are several other things that have mortality benefit in systolic heart failure, so I'm just going to go over those really quickly as well. Well, not necessarily mortality benefit. This one doesn't, but I like to have one thing in my dot phrase about iron replacement. So there was this trial called the FAIR HF trial, and this showed that replacing iron in patients with heart failure with reduced EF is associated with improved, walk test, a 6-minute walk test, and also improved quality of life. So this should be replaced if they have a ferritin less than 100 or a ferritin less than 300 with a transferrin saturation less than 20%. This is as opposed to typical iron replacement thresholds where it's more like ferritin less than 30 or so, because this is how the FAIR-HF trial did it. And the way that I like to replace iron is with iron sucrose, 200 milligrams for 5 days. I do have another video on iron replacement and different methods you can do that in another video if you're interested as well. The other things that have mortality benefit are going to be an implantable cardiac defibrillator and something called cardiac resynchronization therapy. So an ICD is going to be indicated in several different scenarios. So one of them is if a patient has EF less than 35% after 3 months of optimal guideline-directed medical therapy. This is because patients with persistently low EF are at high risk for dangerous arrhythmias, and this is called primary prevention, where we are implanting this defibrillator that will prevent sudden cardiac death. This guideline with the 3 months of optimal medical therapy is generally for patients with ischemic heart failure or ischemic cardiomyopathy. Remember that they have the higher risk for arrhythmias, but you can consider it generally after 180 days or 6 months or so in patients with non-ischemic cardiomyopathy as well. Both of these are called primary prevention of sudden cardiac death because they've never had an episode of sudden cardiac death before. However, if a patient has had a history of a fatal arrhythmia, so any patient with a history of sudden cardiac death, then this is also indicated, and this is called secondary prevention. For the cardiac resynchronization therapy, this is indicated in any patients with an EF less than 35%, with a left bundle branch block and a QRS greater than 150 milliseconds. The way I like to describe this is, drawing a heart like here, and you have your whole conduction system that's running in the middle, right? So you have something going from your SA node to your AV node, and then you have the bundle of His, and then the Purkinje system. So it's going like this. All the electrical signals are traveling in your heart. However, in this case, you have a left bundle branch block. And so what ends up happening is that your right ventricle contracts before your left ventricle contracts, and then you get this really out of sync, basically this desynchronous beating of your heart, which actually causes your EF to remain low and could potentially drop your EF even more over time. And so what you do is you place this cardiac resynchronization therapy in there in order to sync both of the chambers of the heart back up again so that your EF is not dropping due to desynchrony. This again has been shown to have mortality benefit. And the last thing we talk about is preload. Now this is basically talking about how much water is returning to the heart and is getting to the heart. And obviously, if there's too much preload, it overstretches the heart, and then the heart is not able to beat as effectively because it's just so stretched out. And so a lot of times we need to give diuresis to improve the symptoms for the patient and also help the cardiac output out. So this is with diuretics like Lasix or Bumex or torsemide. Remember that this does not have any mortality benefit, but it does have symptomatic benefit and also does help improve the cardiac output a lot of times, because if you remember that Frank-Starling curve, where things, if they get too far off the Frank-Starling curve, you start to lose your cardiac output and stuff. So this is why preload is very important. But again, no mortality benefit. However, people will sometimes ask you, what should a patient's dose be if they are admitted to the hospital? And there was this trial that was done called the DOSE trial, which basically recommends doing 2.5 times the patient's home dose when the patient gets admitted. Frequently, what we do end up doing is doing just 2 times the home dose. So we convert whatever Lasix dose they were on to an IV dose, and that's going to be double. If somebody's in florid cardiogenic shock or really severe heart failure, then we oftentimes go much more aggressively than this. But at the very least, you should convert their PO, like Lasix 20, to IV Lasix 20, and that essentially is doubling their dose. Lasix is typically our go-to for preload reduction, but some patients do benefit from switching to Bumex because there's some thought that if there is so much volume and gut edema, it's actually going to reduce the bioavailability and absorption of Lasix. So Bumex can be considered if really severe gut edema and somebody's not diuresing well on Lasix. Do note that Bumex has an increased risk of myalgias, which can be one reason that patients don't adhere to Bumex. And then torsemide has a longer duration of action compared to Lasix. So sometimes this helps diurese patients a little bit better as well. But there were some trials that were done that did not show any mortality or huge symptomatic benefit of torsemide against Lasix. But a lot of times we switch to torsemide if we feel like a patient's Lasix might not be lasting as long as it should be. There are conversion tables that you can quickly Google on Google Images to quickly convert from one dose to another, and it's something I frequently refer to when I'm switching a patient's doses around. All right, so that's it for systolic heart failure. I mean, I say that's it, but obviously there's a lot of things to consider when you're treating a patient with systolic heart failure. Really, you need to make sure they're on those 4 pillars of guideline-directed medical therapy, but there's just so much evidence and different trials that have been done on things that have mortality benefit that it becomes this huge list of things that you got to kind of check off every time you have a patient with systolic heart failure. Now, this is going to be contrasted to diastolic heart failure, where we don't have as much evidence for things that have mortality benefit. So again, this is why it's so key to differentiate between systolic and diastolic heart failure, because when I was a medical student, I was like, why do we care so much if it's systolic or diastolic? And this is really the reason why. So let's zoom in and start talking a little bit more about diastolic heart failure again. So diastolic heart failure has many different etiologies, and typically you're going to see the most common etiology is going to be long-standing uncontrolled hypertension, but other things can also cause diastolic heart failure, like infiltrative diseases, like amyloidosis, sarcoidosis, and scleroderma. And then also you have restrictive cardiomyopathies, like constrictive pericarditis or post-radiation fibrosis, or just calcification of the outside of the pericardium. And again, this is the reason it's causing diastolic heart failure is because you don't necessarily have an issue with the contraction or contractility of the heart, but it does have an issue with filling because there's just so much pressure on the outside. It's restricting the ability of the heart to fill. And then you have all these different sorts of chronic diseases that can contribute to diastolic heart failure over time. So things like obesity, type 2 diabetes, COPD, CKD, basically all the chronic diseases that people can have. Sleep apnea is another big one. So what is the treatment that we have for this? Do we have guideline-directed medical therapy for diastolic heart failure? The answer is no. So this is significantly different, again, from systolic heart failure. But the old answer was we don't have any treatments that provide mortality benefit. The only treatment or the mainstay of treatment is treat the underlying disorder. So if somebody has uncontrolled hypertension, for example, then we need to treat the hypertension. So this was the old example that, when I was in medical school, that was the answer when attending PIMTU, treat the underlying disease, treat the underlying disorder. However, more recently, there have been some trials that there are some medications that may have some quality of life or hospital exacerbation or mortality benefits. So now, this is kind of more recent, we do have some evidence that mineralocorticoid receptor antagonists, such as spironolactone, may reduce the risk of recurrent exacerbations of heart failure, so decrease hospitalizations, but no mortality benefit. And this is per the TopCat trial. And then we also have some evidence about SGLT2 inhibitors. So SGLT2 inhibitors, like empagliflozin, actually does have decreased cardiovascular death. And this is per the Emperor Preserved trial. So while the answer in the past was we don't have any medications to treat diastolic heart failure, still, obviously, in comparison to HFrEF, that is very much the case. But now we do have 2 medications that potentially have some benefits for patients with diastolic heart failure. Still, the mainstay of therapy is going to be treating their underlying disorder. Finally, a couple other key points that I wanted to talk about before we end out this video. So mortality. One question that you may be asked by your attendings is there a difference between systolic heart failure and diastolic heart failure in terms of mortality? And you may think that initially, wow, systolic heart failure, the EF is dropping. This seems more severe. This is more dangerous. And a lot of times that's how we kind of treat systolic heart failure. It seems kind of more urgent because there's so much stuff we have to do. But actually, there's been multiple studies that showed that the 5-year mortality of both systolic heart failure and diastolic heart failure is 50%. So a lot of times we have patients come in with diagnosis of heart failure and we kind of treat it, oh, this is just like some chronic condition. We're just going to give them Lasix and get all this fluid off of them. But it really is a high mortality condition. And so it needs to be taken very, very seriously, even if somebody's heart failure seems to be relatively stable. Another thing I want to talk about briefly is coding and billing, because when you're an intern, the specific way that you write this problem in your notes is very important, and the coders are always going to get on you for this. So the first thing you need to talk about is the acuity. So is this acute? Is this chronic, which means it's stable? Or is this acute on chronic? So, and then basically acute on chronic means like a heart failure exacerbation. Acute means this is like new onset systolic heart failure. The other thing that they want to talk about is this systolic or diastolic, or is it mixed? So for example, the way I would code this would be acute on chronic systolic heart failure exacerbation, or chronic diastolic heart failure if it's stable. If you just put HFpEF or HFrEF, then somebody is definitely going to contact you to edit your note and try and fix that. And then some other things that we tend to really like to include in our notes for these patients is going to be whether it is ischemic or non-ischemic, because again, I told you that was pretty important. And then we like to sometimes include what's called the NYHA, New York Heart Association class, and the ACC stage. So most of these patients, they're going to be NYHA stage 2 or 3, which means they're symptomatic with kind of minimal activity. And then ACC stage C, which means a lot of times they have some structural changes and they have signs of heart failure. That's going to be the most typical patient population that you're going to see. And most of the time in your note, you're going to want to include a dry weight, so that you know what the patient's original weight is and how much additional fluid they have. Like, are they 10 pounds fluid overloaded, or are they 50 pounds fluid overloaded? This gives people who are taking care of the patient a sense of how much more a patient needs to be diuresed before their heart failure exacerbation is pretty much back to baseline. I hope this video was useful. Please let me know down in the comments below if you have any questions, comments, or anything else that you wanted me to discuss. Thanks again for watching. I'll see you in the next video, and peace.